So let me formally welcome everyone. Good evening and good afternoon, esteemed doctors who joined this webinar. I know many of you will be joining, and also the distinguished speakers and my colleagues. As we know, cardiopulmonary bypass, assisted cardiac surgery is a life-saving system, but it's often triggers significant inflammatory problems which can respond in a various way of post-surgical complications, and it can impact on the patient outcome. We have a privilege to have leading experts in this field with us today from Malaysia and Iran. They will share invaluable insight into their practical experience and the outcomes observed with their use of Jeffron's Hemoadsorption cartridge HA380 during CBP procedure. Today's our agenda is going to be, before I talk about agenda, let me give you a few words about my company, Jeffron Biomedical. This company is established in 1989, and the company is listed in the stock market in 2016. And our clinical use of this hemoadsorption technology is more than 20 years. And we do have international quality certificates like CE, MDA, and ISO. Our company globally using around 92 countries. And our core technology, which is hemoadsorption, is used around 8,000 hospitals worldwide annually with clinical applications of 5 million cases per year. Today's our agenda, the first speaker is Professor Dr. Sivakumar Krishnaswamy. He talked about the role of hemoadsorption in cardiac surgery, Malaysian experience. And Professor Dr. Kamran, experience of hemoadsorption in cardiac surgery. He will be discussing with you with the case studies. Then we can all have a discussion and Q&A and summarize it. We expected to finish this presentation in 1 hour, but if it's wonderful discussion going on, we can still extend it. So first, let me introduce Professor Dr. Sivakumar Krishnaswamy, a distinguished professor and senior consultant cardiothoracic surgery at University of Malay Medical Center, Malaysia, Kuala Lumpur. He holds an MBBS, MRCS, MS, FICS, and FETCS. His advanced trainings include aortic and thoracic fellowship in the UK and unipolar fellowship in Shanghai. His noticeable awards include the MRCS Edinburgh Gold Medal in 2006, and the Al-Hadi Gold Medal in 2010, and being the first Asian EBCTS Gold Medalist and the top scholar in 2016. Professor Dr. Sivakumar, clinical experience, expertise encompasses cardiac surgery, comprehensive aortic surgery, and minimal invasive thoracic surgery via unipolar VWATS. There's so much to speak about him. We have this privilege to have him as a speaker today to discuss with us the Malaysian experience of cardiopulmonary bypass surgery with the HA380. Sir, I'm welcoming you.
Thank you, Sumesh, for your kind introduction, and thank you to Jeffron for giving me this opportunity to share our humble experience from Malaysia. Let me just share my screen. Okay, are you all able to see the screen? Sumesh, are you able to see?
Yes.
Okay, I'll start off.
Perfect.
All right, okay. So without any further delay, let me just start off by introducing myself. I'm Professor Sivakumar from University Malaya, and we are the oldest university in Malaysia, and our cardiac unit is the oldest cardiac unit in the country. So we are here to share our humble experience in the role of hemoadsorption in cardiac surgery, our Malaysian experience. So I'll have a bit of introduction to HA380, a bit about the principles of HA380, and one of my medical officers has done a little bit of data collection and made it into a study where I'll talk a little bit about a study objective, methods, patient demography, primary outcome, secondary outcome from the data he has collected. some key findings based on the data collected and my own personal experience, some comparative analysis, and a little bit on discussion and conclusion from that. A bit of a disclaimer, I'm not a proctor for this product. I'm a proctor for Percival Sutureless Valve. Okay, so to talk on introduction, despite decades of innovation in terms of surgical techniques, cardiopulmonary bypass and perioperative care in heart surgery is still associated with a lot of adverse events. One of the main things is systemic inflammatory response syndrome, and CPB enhances the various degrees of systemic response that is self-terminating in some circumstances by organ failure and worsen outcome. As you can see here, with the advance of SIRS, there'll be a lot of release of interleukins, tumor necrosis factors, and also overt response to the inflammatory, which basically gives a first hit and second hit through the SIRS. So just like how septic shock happens in the body, with SIRS, we end up getting a cytokine storm, there's vasodilatation, and this causes vasodilatation and a lot of inflammatory response and leakiness to the vessel, and that requires a lot of inotropic requirement and other adverse events to the organs in the body. So with cardiopulmonary bypass, there's initiating factors like contact activation, ischemic reperfusion, endotoxemia, immune systemic activation with complement cytokines, coagulation and fibrinolysis, endothelium activation, and also cellular immune system, which all then encompasses into the overt effect of SIRS. And here we have got HA380, which then work as a hemoadsorption, not absorption, but absorption, where the principles of adsorption is they tend to bind with the cytokines rather than absorbing it. And with the resin coating technology, that tends to hold and allow a larger molecule binding and allows further inflammatory binding cytokines, which actually gives a better effect in terms of the results with SIRS and vasoactive component of cardiopulmonary bypass. So our study objective is to evaluate a real-world efficacy of HA380 hemoadsorption to compare the outcomes with literature-based control cohort and to focus on primary outcomes, mainly acute kidney injury and hemodynamic stability. So we conducted a retrospective review analysis of 19 high-risk cases that we did in our cardiac surgery patient. And these are basically cases where we looked at the primary outcome, where the incidence of acute kidney injury and hemodynamic instability. We also then did a literature review based on control cohort of these 19 patients, where we then compared with systemic review and trials for comparative analysis, and they were compared using Fisher's exact test and Mann-Whitney U test. So in terms of gender, our patient demographic, mean age was about 46 years old. Gender majority were male. Euroscore was around 3.7 plus minus 3.6. CPB was mainly because these were multiple procedures and high-risk cases in the average of 266. There were 6 urgent cases and 13 elective. Acute kidney injury was seen in about 5, where 2 in male and 3 in female. Pneumonia, we saw in about 10 patients. Inotropic requirement, maximum inotrope in terms of mean was about 2.2 days, male and female about the same. In terms of duration, average was about 6 days, as these were all high-risk cases. In terms of primary outcome, where we were looking at AKI, high inotropic use, and pneumonia, AKI was about, if you call in percentage, was about 25%. High inotropic use was about 45%, and pneumonia was up to 50%. 30-day mortality was about 3 patients, it's about 15.8%. Length of ICU stay average was about 12 days. Antibiotic duration was about 12 days. Duration of ventilation was about 2 days in average. Secondary outcome, our 30-day Mortality, as I mentioned, was about 15%. Median ventilation days was 2 days, and median hospital stay was about 12 to 13 days. Key findings that we found, the one that was statistically significant in the group that used Jeffron was the duration of inotrope. The p-value was about 0.049, and the rest of it did not show any statistical significance. So our key findings that we found in our small cohort of study was there was a gender disparity where the female patients required a significantly longer duration of inotropic support than male, and that indicates a pronounced difference in post-op hemodynamic recovery despite using the uniform Jeffron application. Strong trend in gender-specific mortality, while not statistically significant. We found female patients carried a higher mortality. CKD as a potent risk factor. Patient with pre-existing CKD showed a strong but not statistically significant data despite using Jeffron. Age and comorbidity burden. Older patients had a notably higher incidence of pneumonia, but not statistically significant. And patient with multiple comorbids showed a worse outcome across all endpoints, though this did not reach any statistical significance in this small sample. So the comparative analysis, where we compared with other cohorts in the supporting literature that used Jeffron, we found a statistical significance with AKI, and this was looking at the Bianchi et al. Paper in the Brazilian journal, which was published in 2023. No other statistical significance in pneumonia, high inotropic use, or 30-day mortality. So Jeffron demonstrates a statistical significant benefit in renal protection, and the incidence of AKI was 26.3% in Jeffron group compared to 47.4% in the hypothetical control group. And this difference was statistically significant, and this aligns with the proposed mechanism of action of HA380 cartridge. By absorbing inflammatory mediators and cell-free hemoglobin, it likely reduces the inflammatory insult on kidneys, thereby demonstrating a direct and significant protective effect. This support the argument that Jeffron is a significant tool for renal protection. The next to highlight is Jeffron shows clinical important trends in hemodynamic stability and survival. The Jeffron group required less high-dose inotropic support, 47.4% versus 68.4%, and had a lower mortality rate, generally 15.8% versus 31.6% in the comparative group. While these are not statistically significant, they are clinically important and consistent with findings from the REMOVE trial and other studies. By modulating the systemic inflammatory response, Jeffron appears to contribute to a greater hemodynamic stability and improve survival, though a larger study is needed to confirm this with a stronger statistical power. So in conclusion, CPB is often associated with degrees of complex inflammatory response mediated by various cytokines. This response can, in severe cases, lead to systemic hypertension and organ dysfunction. Cytokine removal might therefore improve outcomes for patients undergoing cardiac surgery. Jeffron HA380 showed significant absorption of cytokines, improved hemodynamic, and decreased vasopressor needs, and reducing the mechanical ventilation time and the ICU stay for patients with cardiac surgery. And we saw this in our small series in Malaysia. And I have to say that for the 19 cases I used, I found relatively a positive impact in terms of inotropic usage and ventilation duration, and also the AKI. Although we did have 3 patients that passed away, although they used Jeffron, but these were all very high-risk cases where we used Jeffron in a setting where we had not much options in terms of handling this cohort of patients' septic shock in the post-operative period. With that, thank you.
Thank you. Thank you very much, Professor. Really, it was a wonderful presentation. And in fact, I really want to express my sincere gratitude for your kind topic. And I do very well know this case study series was not supported by Jeffron. You did it independently. So the values are really, as we can discuss, if you're really kind enough to stay for completing our second presentation, then we can discuss both of these together. I particularly appreciate the segment where the inotopic support and the AKI reduction in the HA group, which is we should really discuss more. And are you okay, Professor, to stay back for completing the next talk?
Yeah, sure, not a problem.
Thank you very much. So now let me welcome Professor Dr. Kamran Balbasa. Sorry if my pronunciation of the word. He's the director of the cardiac surgery department at Milad Hospital and the chairman of cardiac surgery department at Behar Hospital in Tehran, Iran. With over 24 years of clinical experience in cardiac surgery, his expertise include minimal invasive cardiac surgery, aortic operation, mitral valve repair, and surgical AF ablation. Professor also demonstrated a very good, strong leadership across the major hospitals in Tehran, while number of hospitals he's consultant to. He's dedicated to advancing the cardiac care through innovation and better technology in that. And Professor's experience with the Jeffron's Hemoadsorption cartridge is specifically in complex cases such as IE. And in this presentation, which is titled Experience with Jeffron Hemoadsorptions in Cardiac Surgery, he will share his insight of series of case study on these complex cases. So without further ado, let me welcome Professor Dr. Karman for his speech. Sir, the screen sharing is yours. Yes, I can see your screen. You can make it play. Perfect, Professor.
Good day, everyone. It's a pleasure to be here. And before I begin, I would like to express my sincere gratitude to Jafran Biomedical for arranging this webinar and extend my special appreciation to their representative in Iran. And many thanks to my distinguished colleague, Dr. Krishnasamy, for his valuable collaboration in preparing today's session. As all of us know, modern cardiac surgery aims to correct structural heart diseases while minimizing disruption to the patient's homeostasis. Inflammation following cardiac surgery is a common response, with cardiopulmonary bypass playing a significant role as an extracorporeal circulation method known to trigger inflammation. It seems that duration of CPB represents the determinant of systemic cytokine response, and that CPB and the cytokine response are involved in subsequent organ dysfunction. Moreover, inflammation is not limited to cardiac surgery alone. It's also been observed following implantation of stents, aortic stent grafts, aortic valves, heart-rhythm devices, and radiofrequency ablation. Accumulation of some cytokines with different peaking patterns are also observed in off-pump surgeries. CPB appears to trigger and sustain the inflammatory response primarily in the early postoperative phase. Surgical trauma itself becomes the primary driver in the later phase. A prolonged increase in inflammatory cytokines during the late phase may contribute to the risk of postoperative cardiovascular events. Human biology's response to surgical trauma and CPB often results in an exaggerated, complex defense mechanism involving multiple cellular, humoral, metabolic pathways, and endocrine systems. CIRS is linked to poor outcomes even in otherwise successful operations. SIRS is associated with postoperative complications like myocardial injury and infarction, respiratory failure, renal dysfunction, neurological dysfunction, excessive bleeding, altered liver function, multiple organ failure, and death in severe cases. Specific preoperative and intraoperative factors have been identified as predictors of SIRS and its impact on patients' outcome, including baseline leukocytosis, lymphopenia, thrombocytosis, anemia, female gender, peak lactate levels, and vasopressor support. SIRS is more prevalent in emergency coronary bypass and is closely linked to respiratory dysfunction. Despite advancements in perfusion technologies and biocompatibility of materials, certain patients remained at high risk for complications, multi-organ dysfunction, and mortality. This includes those undergoing reoperations, aortic arch surgeries, correction of infective endocarditis, and hypothermic circulatory arrest for aortic dissection. In order to mitigate inflammation, administration of neither perioperative methylprednisolone nor pexalizumab, a recombinant antibody fragment that targets and binds human C5 complement, showed a significant impact on perioperative morbidities and mortality in cardiac surgery. Efforts to reduce complications in cardiac surgery has long focused on removing harmful substances from the blood of patients with inflammatory or related disorders to improve outcomes. Modern hemoadsorption aims to remove solids, cells, and pathogens that are not effectively cleared through standard diffusion, convection, and due to their size, protein binding characteristics, and lipophilicity. This process involves the dynamic bindings of blood-based adsorbates to a solid surface through a combination of hydrophobic interactions, van der Waals forces, and charge-induced interactions. It targets a broad spectrum of molecules with a molecular weight under 55 kilodaltons, in contrast to absorption, where substances are taken into the physical structure. Unlike dialysis, hemoadsorption does not rely on diffusion, but instead requires direct contact between blood and plasma and a highly adsorptive biocompatible material. Originally used for exogenous intoxication, current data has focused on biochemical effects such as reduction of endotoxins, clearance of unwanted therapeutic drugs like apixaban and ticagrelor, and microbiological effects like virus removal. It should be noted that in the near future, surgeons will more frequently perform emergency operations for patients on direct oral anticoagulation therapies. Perioperative bleeding occurs in over 30% of patients on ticagrelor undergoing isolated coronary bypass before completing the recommended 3-day washout. This will eventually bring in an excessive risk of postoperative bleeding following emergency cardiac surgery. Therefore, surgeons must be ready to deal with an emergency cardiac operation for direct oral anticoagulations using patients. While many studies support its use in cardiac surgery, its effectiveness and clinical relevance remain debated. Pilot studies suggest physiological benefits. Larger studies on endotoxin-based hemoadsorption indicate potential phenotype for future randomized controlled trials. Hemoadsorption has shown promising results in altering prognosis in sepsis, septic shock, and systemic inflammatory syndromes. Meanwhile, current data support its biocompatibility and safety, feasibility, and experimental target removal. There are a bunch of supporting evidences consisting of systemic reviews like the role of hemoadsorption in cardiac surgery by Tillman and colleagues, or impact of hemoadsorption in infective endocarditis by Folliot and colleagues. Hemoadsorption in neonatal surgery from Torino Children's Hospital, and the results of STAR-T randomized trial, which published in JACC 2025 by Michael Mack, are among these evidences. In another literature review, Vitor Mendes showed the effect of hemoadsorption in apixaban removal and reduction of bleeding risk. From Sorbonne, Freyring and colleagues found the potential of hemoadsorption in removal of apixaban in heart transplant, and Furukawa from Melbourne University showed the feasibility and effectiveness of Jafron cartridge in ticagrelor removal. Hemoadsorption provides filtering support and removes anti-inflammatory mediators. However, concerns include potential adsorption of essential therapeutic drugs, possible removal of necessary anti-inflammatory cytokines, and cost effectiveness. Current evidence suggests acceptable short-term biocompatibility and safety, but large-scale randomized controlled trials are needed. There is insufficient evidence to guide the initiation of hemoadsorption aimed at restoring immunologic balance by reducing the plasma concentration of pro and anti-inflammatory mediators below toxic thresholds. Early initiation of hemoadsorption seems to have a more significant impact on patients' outcome. If hemoadsorption is considered, it should not be viewed as a Lazarus therapy. As a Persian metaphor, بعد از مرگ سهراب نوشدارو, which means after the death of Sohrab, the medicine is useless, reminds us that early intervention is the key, which originates from the Persian epic Shahnameh by poet Ferdowsi, where Sohrab, the son of Rostam, is unknowingly killed by his father. Our experience: since December 2024, 18 cases received Jafron hemoadsorption technology for different purposes, mainly to mitigate inflammatory response in high-risk operations or reduce bleeding tendency by removing anti-thrombotic agents, and an exclusive case of postoperative liver failure. Unless our first case, which was a low-risk candidate, nearly other had significant risk. Our first case was a 38-year-old male with severe aortic stenosis, low Euro score, and the operation was minimally invasive aortic valve replacement. And the reason for employment of Jafron was familiarity of surgical team with this device. Results was uneventful postoperative course. Our second case was a 75-year-old female, morbid, obese, diabetic, hypoalbuminemic, severe left main stenosis, septic, chronic renal failure, bedridden, history of cerebrovascular accident with angina at rest. And according to the heart team, intervention was not possible, and we were obliged to bypass her in an urgent basis with expected perioperative mortality around 30%. Operation was urgent coronary bypass, and the reason was comorbidity. Result was uneventful early postoperative course, early extubation, no inotropic support, but complicated lately due to lung aspiration. Our third case was a 75-year-old male, severe coronary artery disease, diabetic, smoker, history of cerebrovascular accident with Euro score around 4.5. Operation was urgent coronary bypass, and the result was uneventful postoperative course. Our next case was a 58-year-old male, diabetic, severe coronary artery disease, obese, active psoriasis, and lung chemical poisoning in the past. The reason was urgent operation, active inflammation, and Euroscore around 4.8. And the operation was urgent coronary bypass with uneventful postoperative course. Our next case was one of the toughest in this series with a 77-year-old male, aortic dissection type A, coronary artery disease, degenerated previous biologic aortic valve 5 years ago. He underwent coronary bypass plus AVR with trifecta, and the reason was high-risk radio operation. Euroscore was around 35.27, and result was uneventful postoperative course and discharge on postoperative day 7. Our next case was a 75-year-old male, acute aortic dissection type A, coronary artery disease. The reason of employment of Jaffron was high-risk aortic operation. Euroscore was around 7.5, and the result was uneventful, and the patient discharged on postoperative day 7. Our next case was an infective endocarditis case on mitral valve. The reason was sepsis plus high-risk surgery with Euroscore around 9.2, and the operation was mitral valve repair with uneventful postoperative course. Our next case was a 75-year-old female, severe coronary artery disease, previous coronary bypass, occluded all grafts because probably due to thrombophilia, and the Euroscore was 5.28. The operation was redo coronary bypass. The reason was high-risk coronary bypass with thrombophilia. The result was uneventful postoperative course. Our next case was a 38-year-old man with bicuspid aortic valve, ascending aortic aneurysm, Euroscore around 13%. Operation was ventral operation and coronary bypass. The reason was high-risk aortic operation, and the patient discharged on postoperative day 8. Our next case was an 82-year-old female, huge ascending aortic aneurysm plus coronary artery disease with severe aortic insufficiency, transferred to the operating room, intubated. The Euroscore was 29%, and the operation was AVR plus ascending aortic replacement plus cabbage. The reason of employment of Jaffron was very high-risk urgent operation. Result was uneventful postoperative course, and the patient discharged on postoperative day 7. Our next case was a 72-year-old gentleman with coronary artery disease, severe aortic insufficiency, LV aneurysm, very low ejection fraction with the history of chronic obstructive pulmonary disease, diabetic, and addict. The Euroscore was around 16%, and the reason was high-risk operation. This patient discharged on postoperative day 6. Our next case was a 52-year-old gentleman with acute coronary syndrome, primary PCI on LAD, which was partially successful and received ticagrelor. We obliged to do the operation within 36 hours of receiving ticagrelor. The Euroscore was not that much high, and the operation was coronary bypass within 36 hours of ticagrelor discontinuation. Event was uneventful postoperative course without any significant post-op bleeding. Our next case was a 51-year-old male, known case of chronic renal failure under hemodialysis with coronary artery disease, very low EF, severe pH, severe TR, and a mass in right atrium, probably inflammatory, and increased liver enzymes. Bleeding tendency was a major concern, and Jaffron hemofilter employed for this purpose. Cabbage plus TB repair was done with non-significant postoperative bleeding and discharged on postoperative day 6. Our next case was a 71-year-old lady, coronary artery disease with severe mitral regurgitation or receiving apixaban, and ejection fraction was 50%. The reason of the employment of Jaffron was operation within 48 hours of apixaban discontinuation and excessive bleeding risk.
Thank you. Thank you very much, Professor. That's really very insightful, and really, thank you very much. Really, your presentation is really covered a lot of case studies with Jaffron HA380. I really hope that we would have did it in a really very formal way, that we can really publish it with a very official way of it. And again, your expertise and insight in this complex cardiac surgery was really illuminating. And you, because of the time, maybe you make it quite short on it. So in fact, thank you very much, both of you. Let's now go for the discussion. And for the discussion, I try to answer the questions which we're having in the chat box first. Then followed by that, we could discuss about the most important points and take home messages. So my first question is to Professor Shiva Kumar. It's like there's a question that which, God, I lost it. 1 second. I just tried it, sorry. Maybe I stopped sharing my screen so I can see this question. Fine. It's from Yu Ching. Can hemoadsorption combined with CBP improve post-operative cardiac ejection fraction in patients with heart failure? Alternatively, does combination it with ECMO improve ejection fraction? And Dr. Shiva, can you help me?
Yes, sure, Shumesh. I think Jaffron has got no role in improving cardiac ejection fraction, because ejection fraction if you want to look at it, is mainly related to the cardiac cycle. If at all anything, the only role that Jeffron can play in the cardiac cycle is more in the afterload, where it can reduce the vasodilatation effect in the immediate post-operative period by reducing the cytokines and inflammatory mediators. But it doesn't give a direct effect to improving the cardiac ejection fraction, maybe an indirect way by improving the vascular tone, and that's how it can increase the afterload. Combining it with ECMO, well, only thing I can see again is the inflammatory response or the SIRS that gains a benefit out of it, where the vasodilatation effect gets lesser and with lesser requirement of, I would say, inotropic, mainly vasoreactive drugs. But once the patient is on ECMO, usually we don't need to use much of these inotropic agents, and there's not much role in assessing ejection fraction because we are actually resting the heart and lungs. So I don't see the relevance of that in combining with Jeffron in terms of showing an improvement in the ejection fraction.
Thank you very much. And Professor Karman, do you have any insight or experience to talk about this area, ejection fraction?
As we know that the need for inotropic support is somehow decreased when we use Jeffron, according to the literature and the studies that have been made by and published by the colleagues in this field. So we think that if there is a lesser need to use inotropes, it might affect the ejection fraction and somehow mitigate the impact of cytokines and the inflammatory response that somehow affect the heart. So it's probable, but we need more documents and evidences to talk about this issue. So it's probable, to the best of my knowledge, it would be possible to observe this effect with further studies, and with comparative study might be come to this conclusion that Jeffron has this kind of effect upon the heart and ejection fraction.
Thank you very much. Since we have this chat box disabled, I request everyone to ask your question in the Q&A icon, bottom of your computer or phone. And also you can raise your hand so that we will unmute you, so you can directly ask your question to our distinguished guest speakers. Okay, meanwhile, waiting for that, Professor Shiva, it's really your study. In fact, directly, we never check interleukin-6 or any inflammatory mediators, but it's clear that the incidence of AK was significantly like 26.3% compared to the hypothetical control group 47.4, with a p-value of 0.045. It's quite 20 patients and 20 is quite significantly good outcome. So can you say that Jeffron HA380 is really a significant tool to protect kidney in the real world? I mean, AKI. Can we recommend this as a routine practice for the patient who have a chance of getting post-surgical AKI? And what is your recommendation to our audience? Which are the patients we should select for hemoadsorption, where we will get a chance of AKI post-surgical? And what can be in the real world the selection criteria for the patients?
Okay, I think to answer that, first we have to go to the type of operations we are going to do and the type of patients we are choosing. So we can divide these into two big groups. One is patient-related and procedure-related. So patient-related, mainly patients with pre-existing CKD, patients who are with high Euro score, patients who are basically with infective condition like infective endocarditis, who are in septic shock or with multi-organ failure, or patients who are in the preoperative period who are quite ill, like someone who had acute myocardial infarction, with 1 or 2 organ involvement. These are the cohort of patients I would say we should strongly consider Jeffron. Procedure-related patients that procedures where we require a bit more additional time than usual, like aortic surgeries, patients who are in the redo settings, multiple procedures, infective endocarditis patients where the overt SIRS response may be there. And of course, in emergency surgeries where we sometimes can't predict the situation we're going to face, like in acute aortic dissection or conditions like that, where we may end up operating longer than expected. So these are the cohorts where, of course, AKI risk is high, and I feel the use of Jeffron, we will definitely have a benefit from the use of this device in this cohort of patients.
Thank you. So in such cases, like there is existing kidney issues, or are you really, for example, post-surgical extended systemic inflammatory response we notice, along with the CRRT, do you recommend hemoadsorption, or have you?
Yes, based on my personal experience, after OR, when the patient came back to the ICU, if they are on CRRT already, I tend to continue the Jeffron at least for a good 24 to 48 hours, depending on the clinical response. And looking at the inotropic response, they tend to show some amount of benefit where the inotropic requirement tends to reduce at a faster pace. And also the liver seems to have better protection compared to the rest.
Great, great. We have a question also regarding in your case study, you didn't mention about the post-surgical AKI. Did renal replacement therapy for the Jeffron group? The question is the less number of CRRT you needed in Jeffron group compared to the group you had?
I mean, in our small cohort, I would say yes, there was slightly less AKI in the Jeffron group, but it was not statistically significant because it was a small number of observational study. I mean, if you're going to do a proper one, then we have to really do a proper design, and then only we can actually comment and say that Jeffron actually has a benefit in reducing AKI. But this is all just observational based data that we have. So yes, the numbers were a bit lesser in the Jeffron group, but then again, there could be other factors to that also.
Great. Hope we can really do a good study on that. And also, I got regarding your another one of the endpoint, like the hemodynamic stability and survival. And we found that Jeffron group had very less inotropic support. Of course, not statistically different, as you say, but again, it's really a big difference when it comes to mortality rate shown quite difference there. So can we really say that because of HA380 able to control the inflammatory cytokine like interleukin-6, which is one of the main reasons for the hemodynamic stability which you are observed in your small group. Again, how about the routine test of inflammatory mediators like interleukin-6 to really show, I mean, to qualify this argument or this point that yes, is really hemoadsorption helped there to reduce the hemodynamic problems because of the removal of cytokines. So how about testing cytokines in Malaysia or in your hospitals? Do you recommend that, or we can really still look into the hemodynamic stability and other parameters, judge it?
I think when we are doing any tests, we need to see how this can be translated into clinical benefit. For me, I would say the clinical benefit I can see here is the role of inotropic support, where the use of Jeffron has time and again shown us that the usage of vasoactive inotropes requirement can be reduced, or the requirement is lesser in this cohort of patients. However, applying this into a an investigation-based study, the use of inflammatory mediators or cytokine level testing will be necessary to validate this. because then there will be a scientific knowledge there to correlate that. However, we don't routinely measure any of these inflammatory mediators because one, it is not cost effective, and two, there are only certain specific ones available in my center which I need to confirm with my clinical pathologist. But we tend to look at the inotropic usage and correlating that with the amount that's being used and the duration that is being used when we are using Jeffron.
Thank you very much for such a wonderful detailing it. And we do have one question about to what extent are the apixaban absorption and platelet function preserved distinct process? Maybe they're asking about the hemoadsorption cartridge will remove some drugs on platelet. This is a common question we hear from everyone about the removal of the substances which we really needed, like platelet, albumin. And do you have, both of you have any bad experience of after using hemoadsorption, finding this kind of albumin, platelet, and drug concentration reduced dangerously? Both of you, maybe Professor Kaumann can start with.
Yes. I haven't, but as all of us know as a cardiac surgeons that the platelet count after a open heart surgery will reduce after operation, and we see the decreased number of platelets in studies after the operation. So I haven't seen any significant reduction in comparison with the cases that we didn't use Jeffron regarding the number of platelets. So I don't think so that it's affect the number of platelets in our studies that we met. And I have to reemphasize we seeking the impact of hemoadsorption. We, as Dr. Siva Kumar emphasized and talk about the how we follow the patients, we don't routinely study that cytokines and the inflammatory cytokines after the operation. We don't routinely measure that in the blood or plasma of the patients that receive hemoadsorption. But as a cardiac surgeon and clinician, we seek the impact of the hemoadsorption. And at the time being, I honestly say that we haven't seen any harmful effect of hemoadsorption to the best of my knowledge, and as far as I know, with the small number of cases that we done during the past year. So for the further judgment and a concise talk about the effect of Jeffron, we need at RCTs in this field, and hopefully I think that STAR-T trial regarding the which is the kind of RCTs which was published in 2025 and reported by Michael Mack, is one of these kinds that showed the ticagrelor effect and the effect of hemoadsorption in the bleeding, and we hope that receive more papers and more studies like that was done by Professor Siva Kumar in this field to see the effect of and the clinical impact of hemoadsorption. Thank you so much.
And Professor Shiva, what is your view on that point of removal of necessary essential thing from the blood by adsorption?
Okay, I tend to echo and agree with Professor Kamran. I mean, he's got a fantastic series of cases that he has demonstrated with a vast experience, and I totally agree and echo with him with our limited series that we have. I feel that the reduction in platelet count or any of the other important parameters like albumin and all are quite normal in cardiac surgery. It is not something absolutely abnormal. I mean, we tend to lose fibrinogen first in, when we go on the bypass machine, and that's how we monitor and we replace it if the patient has got bleeding or whatever that comes by. But going back to saying that Jeffron causes a further reduction in this, it's probably not true, because I think the selection of things that Jeffron filters are mainly related to larger molecules and they are more related to the inflammatory mediators rather than things that are essential in the body. So, of course, again, to validate this, we need further detailed studies and looking into all the series of cases that we have done. But generally, it does not affect much with any essential component in the blood.
Thank you. Thank you very much. Also, from Jeffron, Professor Bellon did some studies in sheep, and we found antibiotics absorption is around 15 to 25%. It's not that bad, as you say. Of course, there will be some. Okay. And Professor Cameron, actually, your presentation with a lot of case studies really given a lot of confidence to our audience. So my main question to you is that did you experience any safety issue of biocompatibility or the circuit problem? Did you need to use more anticoagulant or heparin when using HA380 in your CBP circuit? Did you experience any kind of complication, technical problem with the clotting or anything?
Up to the time being, honestly not. I
Great.
haven't received complication with employment of Jafron. I have to reiterate that the tough cases that I presented in this lecture, you know that they are walking on the edge. There is no place for any kind of error, because the patients that are perioperative mortality around 30%, 25%, they are beyond the boundaries of being operable. We were somehow obliged to do this because these kinds of patients were in the hospital, and they were somehow urgent cases that we were obliged, because the heart team didn't do anything like interventions for that. So if we do the operation in a harmless manner, we could discharge the patients on postoperative day 8, 7, 6. These tough cases, it means we didn't receive any error. If the Jafron was somehow harmful or any kind of harmfulness in the Jafron, we couldn't discharge these patients from the hospital. It's another document to me. It's another document that the Jafron is not harmful, but how much is the extent of effectiveness of Jafron? We have to see it and wait for more documents, more evidences, and more papers all around the boards and in other kind of cases. But we do the operations on aortic cases, in infective cases, in tough redo cases that was recommended by the Jafron, and all over the world to employ Jafron for these purposes.
Yes, I know we are almost end of our topic. We do have two more questions, which is like related to same topic, which is here. I feel like the audience have got interest in this area. One of the questions we got is the use of Jafron HA380 reduce ACT reading by removing heparin? So again, I think we answered this already. Of course, there is no any kind of difference we found. It's always just like the normal. And is it Jafron HA380 absorb antibiotics or cardiac drugs? Again, is answered is no. We don't have any our experts are so the percentage. Don't have much bad experience like that. And so finally, I would like to thank everyone, and maybe one more question to both of you. Generally, as we know, post-surgical AKI not only increase the cost and financial burden of patient in CBP, is also increase the complications. So what is your view about routine application of or feasibility of HA380 one cartridge with cardiac surgery in routine in Asia Pacific countries and Middle Eastern countries? Maybe Professor Shivakumar, how do you think, especially in Malaysia, how we can really bring it up?
I think as of now, we tend to use Jafron in high-risk cases or cases where we anticipate there might be prolonged operation, as what I mentioned earlier. Using it in a routine setting, the issue in a setting like Malaysia is mainly related to cost. If the cost is lesser, then of course we don't mind using it for all the patients. But when we have got a cost factor involved, we have to weigh that in terms of our health economics to match for the overall cost of the surgery itself, so that it doesn't overshoot the stipulated projected cost of that particular operation. So that is one hindrance, I would say, in the setting of Malaysia. But other than that, well, we really have to be convinced. For normal routine cases, I don't really feel there will be much difference or additional benefit in using Gefron, but definitely for high-risk cases or cases where there is a prolonged surgical time, the role of Gefron.
Yes, thank you very much. And how about Middle East? What is your views, Professor?
As all of us know, as a cardiac surgeon, we know that the field of cardiac surgery become tougher and tougher. The simple cases are going to be removed from the field of cardiac surgery. The primary PCIs are growing. The PCIs are growing. We have to make clues for the complicated cases in the near future. We have to go to the root cause analysis of the pathologies after cardiac surgery, so that mitigation of inflammation and confronting with the bleeding risk is one of the most important roles of cardiac surgeons to reduce the risk of cardiac surgery for the next patients and in the near future. So I think that the hemoadsorption is one of the clues that might help in this field and improve the results of cardiac surgery for the future. That's my opinion in this.
Thank you very much. And Michelle, I'm sure my tutor Michelle is also in this call, and Connie Wang. Do you have something to add on as maybe you can give a conclusion and thanks to this distinguished guest for closing this webinar. Connie,
Okay,
want to say something?
Thank you so much. Thank you so much, Sumesh. Thank you all, Professor Siva Kumar and Professor Babazada, for your insightful presentation to share your clinical cases and the real world cases, as well as the valuable discussion together. We highly appreciate it for your time and also efforts to prepare today's webinar. And also, thanks for all the audience, our partners and physicians for your participation. We look forward to more opportunity to collaborating with all of you on the clinical study, training program, and also the academic exchange in the future. Okay. And please don't hesitate to contact with Gefron team if you need any assistance. Thank you all. Thank you so much.
Thank you very much, Connie. So with that, we will conclude today's webinar. Again, one more time, thanks to both of you, professors, for the wonderful discussion where I'm sure our audience are enjoyed it, and everyone can join Gefron Club for downloading this video or watching this video, those who really missed the program, and so more evidence of Gefron's products, especially in cardiac surgery, including the TG removal. It's a different topic. You can find it there. And we warmly also welcome in here in Malaysia, in Philippines, Manila, ATCSA 2025 will be starting day after tomorrow. And those who really traveling to Malaysia, definitely please visit our booth, which is collaborate with the Highland, our distributor here. We also have a symposium, a snack symposium for 15 minutes. Please find your time to join us. And again, thank you very much, and have a wonderful evening and a wonderful night, all of you. Thank you very much.
Okay, thank you.
Thank you for having me.
Thank you. Goodbye, everyone.
Thank you all.
Professor Siva. See you again. Thank you.
Yeah, thank you. Bye.
Goodbye.
Bye.
Thank you for your time.
Bye. Goodbye.
Bye-bye.